note of some interesting information among ourselves. So to carry this forward, we had a young girl who was presented to us after 3 weeks of history in a previous local hospital. And it happens to us that the Department of Pulmonology, the Department of Nephrology, and a multi-departmental approach helped these girls to come to a conclusion. So this girl is a known for consultants who actually was the key person to actually make this patient come to our hospital. Now we have Dr. Srikant, who is our DNB final year student, who will bring this case to us, and followed by we will take opinion from our both pulmonology and nephro colleagues. Over to you, Dr. Srikant, and we thank Dr. Mahesh, Dr. Nagarjuna Maturu, and Dr. Rajasekara Chakravarthi sir to being a part of this program. Can we have Dr. Srikant on board?
Yes, sir.
Yeah, please share your slides.
Are my slides visible, sir?
Yes.
Are my slides visible, sir?
Yes.
Yes. Sir, good evening, sir. I am starting the case. She was a 15 years old female, approximately 35 kgs of body weight.
Can you be a little louder?
Yes, sir. Yes. A 15 years old female, approximately 35 kgs of body weight, initially went to a nearby hospital with the complaints of fever, cough, cold, and mild ear pain for 3 days duration. So she was initially diagnosed on OPD basis and upper respiratory infection, and she was advised cefpodoxime 200 mg twice daily, and even after 2 days of the treatment, there was no decrease in the fever, cough. So she again, after 48 hours, revisited the same hospital. As there was no response to the antibiotic therapy, they have advised a CBP and a CRP. So initial labs which were shown and done on a showed a mild anemia and raised CRP. Since even after the 48 hours, there was still persisting fever, they have advised an IV antibiotic on an OPD basis in the form of cefpodoxime sulbactam 1.5 gram BD along with azithromycin 500 BD and nebulizations with a combination of levosalbutamol, ipratropium, and budesonide. Even after 48 hours of IV therapy, patient still had a high-grade fever ranging between 100 to 103 degrees centigrade, degrees Fahrenheit, with cough, and she was having chest pain on cough. So after 48 hours, still because of persisting symptoms, she was admitted to the same hospital. And the initial labs which were done on the day one, it was showing mild increase in the total leukocyte count of 12,300. CRP was still rise compared to the initial values. LFTs were renal function tests were within the normal limits, and other source of infections to look out, they have done a comparison which was nothing much remarkable. So LFT are also within the normal limits. They have done a chest X-ray. The chest X-ray was showing a haziness in the right upper zone, right middle and upper zone. So a CT was done since even after 5 days of antibiotic therapy, still she is having symptomatic. A CT test was done, which was showing a consolidation in the right upper and the middle zone. Here are the cuts, different cuts, and this is the coronal cut. And the report read it as dense area of consolidation with air bronchogram and surrounding ground glassings in the posterior segment of right upper lobe, lateral segment of right middle lobe, and right posterior lobe and superior basal segments. And there was a mediastinal lymphadenopathy. Along with that, the patient was having a focal small cavitated lesion within the consolidation of right posterior basal segments. So interpretation of this CT test reported by the radiologist was mostly bronchopneumonia, and since it is having cavitated lesions, they gave it could be a possibility of having a fungal etiology. So as a part of infection workup, they have done this. They have sent a sputum. Sputum doesn't sputum gram stain and culture doesn't give any evidence of any particular organisms like gram positive and in single short chains and long chains and clusters. So due to since even after 2 days of OP basis treatment and 2 days of IV treatment, after 5 days, still the patient was having a persistent fever and a persistent cough, and the serial CRPs were being on higher side. So they have changed the empirical antibiotic therapy at the admission from cefpozoline sulbactam to the piperacillin tazobactam. Along with for atypical coverage, they have continued the azithromycin. So the next day, after the 1 day of IV antibiotic therapy, they have repeated the complete blood picture, which was showing persistent anemia. The total count are still on a higher side. And since she was having an anemia, they have done a workup for iron studies, which found to have a low serum iron and total iron binding capacity, giving an impression of like an iron deficiency anemia.
Yeah.
So due to even but
Srikant,
sir.
I will just take a few minutes, sir, to actually request Dr. Nagarjuna Maturu to interfere here. Sir, if I look at this case from a perspective of a local hospitals in a district or a tier 2 cities, if a patient, young girl, 15 years old, comes with a cough, sputum, and a consolidation, I can't think anything beyond this at this point of time. And I think the approach which the clinician approached in that hospital from a clinical perspective. So can any insight from your side till this point?
Yes, I think at that point of time, the patient actually had only an acute history. So it's only 1 to 2 weeks of illness. So I think we should, at that point of time, we should not think beyond a community acquired pneumonia. So the only thing was the presence of anemia. HP was low.
Exactly.
But in India, associated nutritional anemia is extremely common. So I would say that in the first 2 weeks, I think we should not think beyond what is common. So we're not wrong in treating it as a community acquired pneumonia. Once the history starts to, the symptoms do not respond beyond 2 weeks, that is when we should start thinking that two things: are we missing anything, or are we dealing with a complication? So I think in the first 2 weeks, if you start thinking, then I think we will over investigate. So we should neither under investigate nor over investigate. So I think at that point of time in the history, so I would not say that we should worry too much or think beyond what is conventional. Even the CT at that point of time, it just had consolidation, nice consolidations in the upper lobe, very, very, very characteristic of a community acquired pneumonia.
And rightly, the gram stain was also suggesting of some GPC cocci in chains and phase. So more inclined toward a strepto or a pneumococci at that point of time.
Correct.
So it's more like a community acquired typical pneumonia with a dense consolidation.
I will just add one thing for the viewers, that whenever we see the sputum report, I think we should understand that the sputum quality also is to be seen. So many times what happens is, it is not sputum, it is saliva which is submitted. So we should, all the labs should actually give an interpretation of the quality of the sputum. In fact, there are criteria for grading the quality of sputum. So we should ensure that it is sputum and not saliva, and then only give importance to what is there. So you look at the number of alveolar macrophages, neutrophils, and then only you decide whether it is actually a sputum specimen or not. If it's a sputum specimen, then as you had rightly said, the presence of organisms on gram stain would indicate that it could be a bacterial infection. Again, I would say that we should give more importance to culture than the gram stain as far as the sputum bacterial pneumonias are concerned.
So exactly, he's pointing out towards the epithelial cells ratio to the polymorphs and alveolar macrophages in a ratio of 25:1. So the more the macrophages, the more the polymorphs, you are probably dealing with a lower respiratory sample than a saliva or just a spit out. So yes, sir, exactly. I was also inclining that at that point of time, they thought of anemia, And I'm very convinced that they worked up for it. They tried to see why anemia. So that was the only finding when I was asking Srikant, so except anemia, any other clues? So at this point of time, anemia. Mahesh, any comments on this? Dr. Nagarjuna sir said ki anemia
Sir.
in Indian setup with
Yes,
8
sir.
and 9
Sir, am I
hemoglobin.
audible, sir?
Yeah, you are here.
So as Nagarjuna sir చెప్పింది కరెక్టే సార్. I'm 100% with Nagarjuna sir at this point. When this patient went to a primary clinician, the type of workup what they have done
Mahesh,
is,
I think your earphones are having some disturbance. You can remove and I think you can talk.
is it okay, sir?
అంటే
Sir, I am
disturbance,
audible?
you are audible, but there is some disturbance
Okay.
coming when. Yeah, please go ahead. Mahesh, please go ahead.
Sir, as Dr. Nagarjuna sir said, it is just, for a primary clinician, it will be a straightforward case, sir. Just like patient presented with a pneumonia, which is predominantly upper respiratory tract symptoms with fever. Initially, everyone will start looking into routine community acquired diseases, and in the same way, the level of anemia that what she had is pretty common in Indian scenario, because nutrition and iron and other things, like in a female with early, in the sense who will be in the early stage of their menstrual cycle, they will be having significant anemia. And we could not see elevated ferritin at this point of time to take significant inflammation, which is contributing to the overall health condition. And the level of CRP is also not that significant to correlate to that with the radiological picture that what she had. So at this point of time, I will also I can also convince for the fact that she was just treated with an antibiotics, and then she presented to us. But if you look into the other side of the clinical scenario, say if that the same patient presented to our hospital, so what can we do better in this particular patient? That is what I think that is the primary importance of this meeting. That's what I can understand. So in this, suppose if this patient presented to us in the initial stage, I think we will be a little bit aggressive in the nature, like as Nagarjuna sir said, we may need to see in it two further aspects, like whether we are dealing with an atypical presentation of any atypical infection, or are we missing any other thing. And when we discuss the same CT findings with the pulmonologist, Nagarjuna sir student, she said like, this is a typical vasculitic picture, sir. This is not looking like a
No, I think
Mahesh, I think that is later in the course.
Later.
Yes, sir. Yes, sir. That's why I'm telling. If this patient has presented to our hospital, we would have done a CT immediately. I think that's a routine thing we try to do. We are not completely depending upon X-ray as of now. We are going definitely ahead and doing a CT. And I just want to clarify my doubt with Nagarjuna sir, that is this CT is a typical presentation of pneumonia, or it's any other clue that we can get with the CT? Because we are not
Mahesh,
going...
there is a small clarity. There are two CT scans. The CT which was shown is only showing predominant consolidation. So that is not atypical for a garden bacterial community acquired pneumonia. Okay, but the CT which you are talking will be projected later. That is when all the things have happened. I think just to clarify for everybody, I will tell that 2 weeks of history is consistent with a severe bacterial pneumonia. So let us not think beyond what is normal unless there are clues.
Yes, sir.
Which are pointing towards something else. Okay, but in this case, only thing was anemia. So here I'm not thinking beyond bacterial pneumonia. No, when a person comes with pneumonia and anemia, what all should we think? It's a focal pneumonia, not bilateral pneumonia. Okay, so focal pneumonia with anemia. One, as I have said, it is unrelated. Nutrition anemia with focal pneumonia, the most common scenario. Second, rarely diseases like mycoplasma can have associated hemolytic anemias. That is something which we may consider if you have picture like this. Second, if you have a bilateral pneumonia with anemia, then you should start thinking of certain other differentials like diffuse alveolar hemorrhage, vasculitis, and all those things. Here we had a focal pneumonia. At a right upper lobe big patch, here small patch with anemia. So at that point of time, we're not wrong in thinking nutritional anemia with associated bacterial pneumonia. So this is at this point. But if the person doesn't respond to 5 days of antibiotics, a conventional community acquired pneumonia will respond to 5 days of antibiotics. If it's not responding to 5 days of antibiotics, then we have to think why. So then I teach my students is you have to think of certain possibilities. One, did he develop any pneumonia complications? Even today we have a patient just now admitted, not responding, pneumonic effusion. Commonest thing, pneumonic effusion. Second is the presence of community acquired MDR organisms. Nowadays, sadly, that is also we are seeing now. So try to look for the etiology by doing whatever you can, sputum culture, if required, bronchoscopy, BAL, bronchoalveolar lavage, and try to look for the correct organism and then see. Then you should think of uncommon causes or uncommon infections first. So whenever I talk about uncommon cause, it's uncommon infection and a non-infectious cause. So beyond bacteria, if the history is beyond 2 weeks, then as per the Indian guidelines, you have to screen for tuberculosis. And of course, if the person has anything to suggest a weakened immunity, you should also think of diseases like non-tuberculous mycobacteria, nocardiosis, all of the fungal infections. We see a lot of non-bacterial infections in our daily practice. It's just that we don't suspect them too much. Last comes the non-infectious causes of consolidation. So actually, when we look at it, we shouldn't call it pneumonia, we should call it consolidation, the radiological picture. So then you should think of non-infective causes. All of these should come after 2 weeks. The first 2 weeks, you will not think of all of these things.
So we will take the case forward, sir, as the case explores. So we will discuss those points. So rightly, we all feel that the primary clinician at his first center has done whatever possible to be done at that point of time, and also worked out for anemia. As rightly pointed out, we do see sometimes hemolysis being associated with mycoplasma as a cold agglutinin being a scenario there. And sometimes, as we said, common association with a nutritional anemia. Over to you, Srikant. You can get.
Yes, sir. So due to persistent high-grade fever and cough, even after 5 days of antibiotic therapy, and the imaging was showing a lobar consolidation, at that treating hospital, they have decided to subject the patient to a bronchoscopy and send a BAL sample, which will be more specific for analysis. But the BAL sample, gram-stain, showed similar type of picture having gram-positive cocci and few DrNB. There were negative for fungal elements and there are no acid-fast bacilli. And after 48 hours, culture also doesn't show any growth and there are nothing suggested of any malignant cells. So they have repeated a complete blood picture again because of persistent fever and still she was symptomatic even after antibiotic therapy. So she was having anemia and CRP doesn't come down, still it is maintained at the same level. And there was no major change in the renal function test or a liver function test compared to the baseline on the day 6 of the hospitalization. So at this point of time, even after 2 days of OP-based treatment and 1 week of hospitalization, the treatment of combination of antibiotics, latestly with piperacillin, tazobactam, azithromycin, but the findings still the patient was symptomatically she was having fever, cough and chest pain. She was having anemia, still high total leukocyte count, maintaining at the same level of high CRP and CT suggestion of consolidation. So BAL also doesn't reveal any specific argument. So at that point of time, they have done a procalcitonin for her, but it was 0.77. So keeping in this background, not responding to cephalosporin group of drugs and 1 week of hospitalization, maybe they are suspecting some secondary hospital acquired infection. In addition to the primary community acquired infection, they have escalated antibiotic. She already nearing to the 2nd week of illness, so they started an empirical ATT therapy. So also they are thought that since the patient is having anemia, raised CRP and not responding to antibiotics, can it be any autoimmune pathology? So they have done an ANA profile. The ANA profile wasn't given any lead. And since she is also into almost into second week of illness, suspecting a fungal, they have sent a serum galactomannan, and they have, along with the ADT, they have also started a voriconazole, and they want to do a tissue biopsy. At the time, they initially planned for a CT guided biopsy. So from day 1 to day 10, she was persistently having anemia.
One slide back. So again, back to this case, sir. I think after a week of hospitalization and antimicrobial therapy, they were thinking in a line of possibilities of a tuberculosis, possibilities of a fungal infection, possibilities of a drug-resistant bacterial pneumonia, and they were also considering a tissue or a kind of a biopsy. So what was this approach, sir, Dr. Nagarjuna Maturu, sir? Any point?
I think, see, the way they approached, I think is very, very correct. So as I have said, if it is not responding after 1 week of a broad spectrum antibiotic, then it is something we are missing. So that much is very clear. So bronchoscopy and BAL they have done. So the technique which has been implemented is again very important, because if it is not done properly, you will not get the diagnosis. So that is one point, but we will presume that it has been done correctly, and still you have not grown any organism, neither TB nor bacteria. So the only thing which I would have done differently is that one, empiric ATT is something which I will not start. So because the role of empiricity in the current generation of diagnostic tools which we have with us has almost become very, very, very less. So empiric ATT is only done when the person is very sick that we cannot do any procedure to confirm, and the person refuses the procedure, only then we resort to what we call as empiric ATT nowadays. So the second thing is empiric antifungal. That again I will not agree for two reasons. The person has no risk factor for a fungal pneumonia. Fungal pneumonia, we should realize, does not occur in otherwise immunocompetent individuals. So I will never start empiric antifungals in a person who looks immunocompetent to me. So these are the two places where I will differ. Now the other thing is working on the lines of autoimmunity. Young female presenting with non-responding lung infiltrates and fever and anemia. I think beyond 2 weeks, we are not wrong in evaluating for an autoimmune etiology. I would appreciate the team that they must have thought about SLE. SLE is the commonest thing, correct? So that's why they have sent ANA profile and everything. But the odd thing is that SLE doesn't present with focal patches. SLE presents either with diffuse alveolar hemorrhage or acute lupus pneumonitis, which are usually bilateral infiltrates. The autoimmune diseases which present with focal infiltrates are those which cause organizing pneumonia. So organizing pneumonia is a non-infective cause of consolidation, and the autoimmune diseases which have an OP pattern, we call it the OP pattern, are more often rheumatoid arthritis, Sjogren's, and myositis. SLE presenting with OP is extremely rare. So if you ask me whether the lung CT fits in with SLE, I will tell no. Okay. Now, what other things can we think is, if you see the report, there's small cavitations happening.
We will come to that, sir.
Yes.
To keep the skip alive, we will continue.
Yeah.
Please. Go ahead.
Yes, sir. So by the day 10, she was still anemic, total counts are still on the higher side, and persistently high CRP levels. So by the third week of illness, she came to our hospital. By the time she came to our hospital, she was already 10 days of hospitalized and received cephalosporin groups, atypical coverage with azithromycin, ATT, and voriconazole. And while the complaint that were present even after 2 weeks of hospitalization was fever, cough, and tachypnea. Only positive findings were anemic, high TLC, elevated CRP, and lead to any specific organism with a lobar consolidation. So on arrival to our hospital, she was having febrile. Maximum temperature recorded was 1 or 2 degrees Fahrenheit. She was having a productive cough. She was tachypnic, maybe due to fever and underlying pneumonia. She was requiring 2 liters of oxygen support. Vital parameters are being maintained. So we sent a regular lab investigations, and as a part of sepsis workup, we sent a blood and sputum for culture sensitivity. And we started on cefporazone sulbactam, a typical coverage with doxycycline, as well as symptomatic treatment. And a team of doctors have examined the patient and planned for either a CT guided or for an EBUS by interventional pulmonology.
Can you show the CT which was done at admission?
Yes.
That will be even helpful.
Yes, sir. It will come in next 2 slides.
Yeah, please go ahead.
So yes, sir. So initial lab was showing same. She was having anemic. She was a progressive thrombocytosis happening, and CRP was also a bit high. Compared to her day 6 creatinine level at the previous hospital to our hospital, that is almost 5 days after this creatinine value, it was a mild increase, 0.77. Her day 1 and day 6 creatinine at that previous hospital was same, but after 5 days of last creatinine value, there was slight increase, that is 0.77. So as we are planning for interventional procedure, so we have sent accidentally it came to be high, which was the first time it was being done in last 2 weeks. And but she doesn't have any bleeding manifestations. And since she was having continuously SOB, so we attributed that maybe anemia is also contributing to her. We transfused her 1 unit of PRBs. And the serum galactomannan test that was done in previous hospital, they have brought those report, which was slightly on a higher, on a positive side. So we continued the voriconazole dose. And the LFTs which were done in our hospital showing increasing trend of bilirubin, no major change in the enzyme levels, but she was having a albumin, hypoalbumin, 2.82. And along with that clinical examination, she was having mild puffiness. So at this point of time, there was INR, but there was no deranged liver enzymes. She was having hypoalbuminemia. So we attributed this hypoalbuminemia maybe as a negative inflammatory marker, and there was anemia. So patient is having having this fever. We want to rule out any thalassemia. So advise the hemoglobin electrophoresis, the ultrasound abdomen to find out any other source of infection other than the lung, which showed that even though the INR is raised, no major change in the liver. There is no hepatomegaly or splenomegaly. Kidneys, they showed a mild increase in the cortical echo texture. And there was a significant grade 3 renal parenchyma. So we have followed her INR continuously, but still even after the vitamin K therapy, there was a progressive increase in the INR value. Since the having low hemoglobin, we want to rule out any hemolytic picture happen. So we have done an LDH which showed raised. Compared to day 1, day 4, there was an increase in the bilirubin. There is a significant increase from thousands of the increase in the enzyme levels and persistent hypoalbuminemia. So hemoglobin electrophoresis is not suggestive of any hemoglobinopathies at this point of time. So we also wanted to rule out any, we are missing an autoimmune pathology. So we have sent an ANIF which came to be weakly positive, and they gave an impression of antibodies against a spindle fiber antigen MSA2.
Dr.
And we have done,
just to add on at this point of time, I think with the coagulation dearrangements and anemia workup, our hematologist was involved, Dr. Ganesh, and he actually did a mixing study in this patient where he suggested that mixing study was correcting the INR. So the lupus antibodies, which can be a possibility, or autoantibodies, which actually can be a cause without a LFT dearrangements, were ruled out, and it was found to have a factor deficiency. And that's where we thought of replacing vitamin K as a corrective measure or a supplementation to see whether there is a liver injury, where we have seen subsequently followed by INR deterioration, there is a liver enzyme which is deteriorated. Somehow with the patient's criteria and background, the hematologist also felt the anemia need to be ruled out from any thalassemic traits kind of thing, if not major. So I think that's the reason he wanted a thalassemia workup. Okay.
So on day 4, there was a significant jump in the total leukocyte count. She was having significant thrombocytosis. There was increase in the creatinine value from 0.77 to 0.83, which was actually basal value was 0.6 at outside hospital. And the CE was showing pus cells, hematuria, red blood cells were present, and 2 plaques of proteinuria. But there were no crystals and casts in the CUE picture. So this was the CT. CT was showing in the right upper lobe, posterior and anterior part, there was showing a consolidations with cavitated regions.
Yeah, so sir, we will take Dr. Nagarjuna Maturu sir's opinion here, and then we'll come back to the CUE.
Do you have more cuts also? Only 2 are
Yeah,
there?
yeah.
Only 2 are there. Okay.
Please,
So here again, see, this is something very important. So basically, what was a clear consolidation now has cavitated. So now we have a cavitating pneumonia, cavitating consolidation as our radiological diagnosis. And if you look carefully here, you can also see what we call as a feeding vessel sign. In the cavity in the middle lobe, the upper one in the picture, you can see that there is a vessel going directly into it. That's called as a feeding vessel sign. So now when we have a young girl with subacute history, so it is now 3 to 4 weeks. So 4 weeks, so it's called subacute history and cavities. So this is where we are. So what should we consider? So again, broadly infectious and non-infectious. When we have a subacute history, you should keep both differentials open. No, infectious, what can we consider? One, obviously, should we still think of bacterial cavity? It is not that complicated bacterial pneumonias can be there, but here the odd things are there is no air fluid level. Usually I will tell that a bacterial lung abscess will have an air fluid level, which was not there in this case. TB definitely in India has to be ruled out, but overall the way the thick walled cavity is there, and the fact that they're not very in the upper lobes, it is in the one in the middle lobe, one in the lower lobe. So it's still, but I will not rule out TB completely. Then other uncommon infections. Here, the thing is that we have not evaluated for the immunity of the child, whether she is having any underlying immunodeficiency. So when we do evaluation for such cases, we also send workup for diseases like nocardiosis, melioidosis. Sometimes we do see all of those things, but because the person, as of now, we don't know what is the immune status of the child, we cannot comment further. Now, the second thing is always in the subacute history, start thinking of non-infectious causes, correct? So in the non-infectious causes, when we have a person with cavities like this, then we always send serum ANCA. So that is for diagnosing vasculitis. Pulmonary vasculitis is a thing which we see not very common, but we do diagnose one case of pulmonary vasculitis almost every month. It is just that we suspect more than others. That is the only reason. The more you suspect, the more you diagnose. If you suspect in 10 people, maybe one you will diagnose, but it is worth it because your treatment is going to change. So whenever we have a person with cavities, so then I think we should always think of vasculitis as one of the causes. Had this person been elderly, smoker, then we will also start think of neoplastic causes and other causes of lung cavities. But because being a young female, we will not think too much of neoplastic causes, but vasculitis definitely at this point of time, more actually when the initial 2 to 3 days, the urine CUE report was not there. When the third day, when the CUE report came, then the suspicion became much higher. But
So
we discuss on CT, this is what I will tell.
Yeah, so go back to the previous slide. So Mahesh, this is again a case where the CUE played a key role, a game changer for all of us. To my surprise, this girl's previous urine sample in the previous organization when he was done a CUE was normal with a creatinine of 0.6, and then it was 0.77 in our place and 0.83 in the day 4. So any clues from a nephrology point of view? I do understand as a clinical clinician, a physician point of view or a critical clinician point of view, 0.6, 0.7, 0.8 in even a 15 years old girl, we may go unnoticed. So we want your inputs in this area with this COV, wherever a previous COV was normal, and there was an ultrasound which is again suggesting a grade 3 renal parenchymal changes. So much before a CT, before we go to the CT. So any clues from here, and what did we actually missed?
Yes, sir. Coming to the first point, as you said, regarding the serum creatinine value, which is slowly progressing from 0.6, 0.7 to 0.87. What we generally routinely do is we would not jump into a renal pathology immediately, sir, definitely, as you said, because the patient is having significant fever from the last 15 days. There could be definitely an element of dehydration for most of the people who will be having fever. Even if you see a person with very high grade viral fevers, they will have an element of dehydration. Once we start the fluid resuscitation, their creatinine slowly again decreases. So at this point of time, definitely based upon the serum creatinine value, we cannot jump that see that there is something renal pathology which is going for her. That is number one. Coming to the next point, what you have raised is regarding the complete urine examination, sir. So this complete urine examination definitely gives a clue that, see, it's like a, we cannot definitely say that this is directly renal pathology, but the renal, see, complete urine examination, which was normal a couple of weeks ago, and once she's getting into our hospital, there is some active urinary sediment. This kind of active urinary sediment is rare in a normal person, sir. We can expect definitely when there is an acute febrile illness, there can be some amount of RBC in the urine. But this kind of 3000 to 4000 kind of RBC will definitely not be seen in routine fevers. Either the patient is having any glomerular hematuria, or if the patient, if it is a female, we just need to check whether she is in menstrual cycle. With that, sometimes it may give false representation of high grade, large number of the RBCs which is seen in the urine. And in the similar way, the type of proteins also, sir. When the RBC are 3440, we cannot directly take the 2 plus into consideration, because we will always equilibrate with the number of RBC and pus cells in the urine. But this is a disproportionate presentation. I think once she came to our hospital, we must have asked that whether she was in regular periods or routine, other causes we have ruled out, and then we have asked for a complete urine examination. This clinical picture and this complete urine examination definitely gives some clue that the patient is having some hematuria which is related to the kidney, because she is having 2 plus proteinuria and enormous number amount of RBCs. And with the history of being, by the time we have done this complete urine examination, we have also seen that there is 1 plus ANA 1:100 in the routine examination, and this would give some clinch or some clue that where is there any something which we are missing for this patient in the background, keeping autoimmune diseases in the background, sir. And next, coming to the ultrasound picture, the ultrasound picture that what she is having like grade 3 echo texture with mild ascites, mild pleural pericardial effusion, whatever it is, we cannot take that into consideration at this point of time, sir. If we see ultrasound examination of most of the sick patients with atypical infections or pneumonia or dengue, we see some kind of periglomerular fat stranding and gallbladder slides. These are like each and every organ responds its own in its own way for all kind of stress that what that organ is going to receive. So we regularly see for most of the patients some amount of perinephric fat stranding in the CT and altered echo texture looking like grade 1 to grade 3 echo texture in acute kidney injury also. So we cannot take that the patient is having chronic kidney disease, and in that kind of, we may just deviate from that regular pathway. So at this point of time, what is the important thing that the patient gave to us as a clue is 1 plus ANA positivity and significant amount of RBC in the urine in the background of no menstrual cycle and 2 plus proteinuria. At this point of time, we just look into a clinical picture that their patient is having some renal involvement. And in the background, as Nagarjuna sir suggested, the way that she is present is not, I mean, after 2 to 3 weeks of illness, it is not looking like a bacterial pneumonia at this point of time. So we may need to think about the systemic causes of renal itself. And because also she had a pulmonary involvement and significant hepatic injury, I mean, the liver enzymes are going more than 1000 with renal involvement. We need to think about multi-system causes of the clinical picture. At this point of time, because she's having fever with some background ANA positivity, we need to look into complete autoimmune profile, sir. I think the next slides are going to discuss about the further autoimmune work of what we have done.
Over to you, Srikant.
Yes. So after the day 4 of hospitalization, the symptom still she was having around 100 degrees Fahrenheit fever. Vital parameters are stabilized. The oxygen requirement came off. There were no bleeding manifestations. The complaint which she has come to us, such as cough and the lung related, have resolved. But new features such as increased INR, increased bilirubin, liver enzymes. So these were the new set of problems with slightly increased creatinine. So we thought at this point of time it can be due to drug-induced liver injury, as we were using voriconazole, and they have stopped the drug and started on NAC infusion. And she was having mild puffiness of the face and along with hypoalbuminemia. So albumin replacement is being done. So by the sputum sample was sent at the end of the came at the late by the night time. So we have sent the sample and the report came after 48 hours, which came to be positive as Stenotrophomonas maltophilia, which was sensitive to levofloxacin and cotrimoxazole. And her blood cultures were sterile. So we have started on injection levofloxacin as a targeted therapy as per the culture sensitivity report, along with trimethoprim and doxycycline was stopped. On the day 5, there was a slight improvement in the total leukocyte count, but still there was a deranged INR, and after the NAC infusion, there was an improvement in the liver enzymes.
Sir, go to the previous slide, Srikant. So Stenotrophomonas multifida from a community-acquired pneumonia. Dr. Nagarjuna Maturu, how do you take it from a sputum sample?
Correct. So I think this was what we had discussed in our rounds also. So see, at that point of time, whatever pure growth is there, we have to give importance to it and treat it. But as I had said in our discussion also, I will not take it as a primary culprit. Correct? Because this is typically considered as a breakthrough infection, usually acquired when a person is in the hospital on multiple antibiotics. Then you get all of these sort of bugs,
escape pathogens.
So I think we should always think of all these things, that if you have considered that this is the cause of the cavities and the pneumonia, we will miss the bus. So this was probably acquired somewhere in the hospitals or whatever it is, but this is not the cause of a primary cavitating pneumonia. So Stenotrophomonas maltophilia has not been described to present as a primary cavitating pneumonia. So that is why I said that though we have an organism, though we will treat it, it is not that we won't treat it, but I will not stop myself from evaluating the case further. At that point of time, because the INR was deranged, so we also thought that let her stabilize, and then we will think of what has to be done. In the meanwhile, the other investigations were happening.
The evaluation was on board, but because of the INR, we were looking at why the INR is high, what is the reason for LFT derangement, and we wanted to go for a procedure later on with the stabilization. Next slide.
So till by day 9, that is, she was having still around 10,000 of total leukocytes. NR got stabilized after the starting of targeted therapy of Stenotrophomonas. Bilirubin still around 6 value, enzymes were maintaining, and surprisingly, the creatinine, which was 0.6 to around 10 days previously, it was slowly increasing and reached a value of 1.65 at the day 9 at our hospital.
Go back to that slide. So, to Mahesh, we were all worried from that 0.83, and the CUV has clues. So there are a culture growth in the Stenotrophomonas. So we were using antibiotic. There was a delay going on at that time with liver enzymes going haywire, INR shoot up to 5. So we were all worried at that point of time, struggling with that, missed the bus with the creatinine being 0.7 to 0.8. So what is your thought process in that? The slowly the creatinine crept to 1.18, 1.35. what could have been done a better way at that point of time with INR of 4.8 and all?
Yes, sir. So coming to the analysis of this patient, sir, it is slowly giving hints that there is some systemic picture, number one. And as Nagarjuna sir suggested, we cannot neglect the infection that what she had. Even though if it is a bug which is a contaminant, we have to treat it. And number two, the level of your liver enzymes which are which were increased in the initially after starting voriconazole, and after stopping it is slowly decreasing. Therefore, based on that, we can take it for granted that the predominant hepatic injury caused for her is because of the drug-induced liver injury. Even if it is a kidney injury, also we will always first see the routine drugs that what patient is receiving. So, because we always miss the drug-induced renal injury element, but at this point of time, as you said, the creatinine is slowly creeping up with the in the background of some completely, I mean, in the sense, not fully treated infection. What we routinely think in our rounds is if the patient is having some infection in the background of some autoimmune positivity and active urinary sediment, we generally what we our working style will be, we take it for granted that this infection has precipitated in the background of any autoimmune disease. This infection has precipitated the autoimmune disease. Then the autoimmune disease might be flaring up, and then that could be leading to the decreased glomerular filtration rate, and in the labs we see increased serum creatinine. Then we may need to think about predominant renal causes at this point of time. We generally ask for complete autoimmune profile along with the vasculitic profile for any patient. And as you said, like we will also think about anti-lupus anticoagulant antibodies. We generally take an opinion from hematologist. Previously, when the hematologist was not there, we directly used to send anti-phospholipid antibodies syndrome antibodies. And the same time, we will also ask for mixing studies to rule out lupus anticoagulant bodies, which was done in this patient, and we have ruled out APLA profile. And the last thing will be like we take it this way: if someone asks us what is the diagnosis from renal point of view, we take it like rapidly progressing renal failure bar rapidly progressive glomerulonephritis. So if we see rapidly progressive renal failure, the differential diagnosis will be acute tubular necrosis, acute interstitial nephritis, and rapidly progressing glomerulonephritis. The clinical picture that what this patient is giving is pointing towards the rapidly progressive glomerulonephritis, sir, because she has an active urinary sediment in the background of some infection, and she is going into rising creatinine. So when we may need at this point of time, if you want to narrow our diagnosis, we will always ask for a patient for complete autoimmune profile, which includes workup for infection related glomerulonephritis, though it was not done for this patient, but we would have done for this patient also, in the sense we would have asked for anti-streptolysin titers, and we will also ask for complement C3 C4, and we will check for anti-glomerular basement membrane antibodies, and we will ask for Cianca Pianca. But as based upon the patient age, based upon the clinical picture that what she is giving, as the treating physician in our hospital done, we will first think about lupus, which is pretty common in her age group. Then we will go back to the each and every other autoimmune disease and infection related glomerulonephritis. And predominantly, if you see from the nephrology point of view, you will always keep IgA nephropathy also at this point of time as one of the differential diagnosis, because they present with very slowly bumping up creatinine with the normal complement levels and significant amount of hematuria, because we routinely call it as a synpharyngitic kind of picture. If the patient has lower respiratory tract infection, then they will present episodic macroscopic hematuria, and their hematuria gets down, and their creatinine will be slowly creeping up. So at this point of time, as
And
sir said,
how frequently streptococcal or staphylococcal glomerulonephritis are non-oliguric? Are they generally oliguric or anuric?
yes, sir. Generally, they will present in oliguric, but the clinical presentation, what we see in this particular group of patients, sir, their creatinine will be little bit on more higher side, sir. They will be coming with 2.53 creatinine, because now, if you see the etiology of infection-related glomerulonephritis, whatever the guidelines suggest is treat it with proper antibiotic. But now, if we see our current Indian clinical practice, everyone is giving antibiotic, and the number of infection-related glomerulonephritis has been decreasing from last 2 to 3 decades. And there is a change in the spectrum of this, definitely the IRGN, sir. Previously, if we see when we are in the first year MBBS or second year MBBS, as you said, we have seen kids, I mean, the same 10 to 20 years old females presenting with a nephrotic kind of picture. They will be having swelling of the face, and their creatinine will be in around 2 to 3, and they will be presenting with hypertension. And if you check the complete urine examination, they will be having subnephrotic to nephrotic range proteinuria with active urinary sediment. But this kind of typical IRGN cases are now we are not seeing, sir. Now we are seeing IRGN predominantly in elderly group who are diabetic from long duration, having diabetic foot and some undiagnosed infection present in the body. They are present with IRGN, and patients with infective endocarditis, which will be having continuous antigenemia. They are presenting, and if there are any plastic materials in the body like shunts or any prosthetic materials, that will be like a seedling material for some infection, and that infection causes significant antigenemia. And there is a change in the trend of this kind of presentation. So we are not, as you asked, sir, we are not typically seeing this infection related glomerulonephritis in young group. Definitely, we are suspecting now routinely IRGN in diabetic patients who are there for in hospitals with long duration, having bad wounds which are not completely treated. Thus, that clinical picture we are seeing. So at this point of time, as you said, sir, we will definitely look into complete autoimmune profile for this patient. And I think the next step is you
Srikant,
have
you
done
can
is
carry on.
Yes, sir. So after by day 9, after the targeted therapy with levofloxacin and cotrimoxazole, from the last 24 hours, patient had no fever, there were no cough, but meanwhile, patient had an intermittent episodes of abdominal pain which was non-tender, but still her facial puffiness were persisting, and there was a persistent hyperbilirubinemia. And coming to next, there was a repeat of again complete urine examination, which was showing again there was a 2 plus of proteinuria and a significant hematuria. And repeat of ultrasound abdomen showed again there was a both kidneys are showing globular with increased parenchymal ecotexture, suggest of an acute kidney injury. So, due to multi-system involvement, the lungs, liver, and kidney, and after discontinuation of fluoroconazole, we thought, though the initially they have done an autoimmune workup, again we considered a possibility of any missing rheumatological and vasculitis was considered as discussed. So, since he was having a proteinuria, we advised the 24 hours urinary protein along with the vasculitis workup and complement C3, C4, and C-ANCA and P-ANCA. There was significant urinary proteinuria and came positive, and C-ANCA came as positive, and with complement levels at the lower normal level.
Go back to that slide. So subnephrotic proteinuria in 12 hours urine protein, and with again continuation of your urinary RBCs and CAS. So what will be your clue here, Maheshi? My debate, just to counter your argument that it can be an autoimmune, I say if I am a clinician in the primary center, I saw a CUE is normal, and the patient received a lot of analgesics, antibiotics left and right. Now his creatinine is rising, and sometimes we may talk about drug-induced, maybe sometime interstitial, and all that comes into my mind. So how do you actually give us a clue that this patient is more of a vasculitic phenomenon than a drug-induced vasculitis or a drug-induced acute kidney injury?
Sir, uh, if there is an extensive discussion from nephrology point of view at this point of time, sir, whenever we suspect significant drug-induced renal injury, the traditional teaching is like look for eosinophils in the urine, sir. And the type of clinical complete urine examination that we get in drug-induced renal injuries little bit different, sir, from this particular patient. We will not see significant amount of RBC, number one. We will not see even 1 plus or 2 plus proteinuria also, sir. We may just trace proteinuria or 1 plus proteinuria, which is usually a tubular range proteinuria, number one. And number two, if we are suspecting significantly drug-induced renal injury, we will ask for urine for eosinophils, sir, definitely. If the urine, because predominantly drug-induced renal injury, the classical histological presentation is acute interstitial nephritis, then we will always definitely look into complete in the urine. We will look for eosinophils. That is number one. Coming to the slide, sir. This is a quite interesting slide. See the if we see the patient age, sir. If we are suspecting vasculitis, whatever the vasculitis that what we have seen till now is the tradition as per the traditional teaching. The vasculitis, the age of the presentation will be more than 50 years. If it is a veganous, it will be 50, and for microscopic polyangiitis 60, and eosinophilic it will be more than 70. Generally, we not routinely see a patient with vasculitis, that too in this particular age group. But this is a 5 to 6 years ago, sir. But now what we see in the literature is, if the patient has a vasculitis and if the patient has a C-ANCA positive, there is some data that the patients who are females and in the early age group, in the sense in the adolescent age group, they are presenting with vasculitis. This is the change in the spectrum from what we have traditionally learned a decade ago, sir. Now, because this is routinely given in the nephrology textbooks, females in the young age group, if they have C-ANCA positive, they are presenting like a vasculitis, and this type of vasculitis is predominantly renal. But this patient doesn't have only renal involvement; she also have a pulmonary involvement, sir. So
So,
at this point of time, what I can suggest is like workup for routine RPGN cases. In the sense, don't only go with ANA profile and don't only go with the C-ANCA, P-ANCA. Always look into anti-GBM antibodies, because anti-GBM antibody syndrome is a has a bimodal presentation. They will be presenting in young age group, at the same time they will be presenting in the 50 to 60, I mean little bit elderly age group also. We need to look into anti-GBM antibodies also. And one more interesting thing in this particular patient is the complement levels. If it is a purely vasculitic disease, the serum complement levels are contrary to our expectations, they will be elevated. So though it is a consumptive coagulopathy kind of picture, in the sense there will be an activation of alternative complement pathway. But if we see the complement profile, the books and the traditional and now the current treatment strategies for anti vasculitis, they are suggesting to use complement inhibitors. So the complement level should be elevated, C3, C4, and from C5 to C9, C3, 9, big B, small b, all these levels should be elevated if it is a typical vasculitic case. But because the picture is little bit different at this point of time, we may need to rule out all the autoimmune diseases. At the same time, we may need to proceed for renal biopsies, because that gives a little
Nagarjuna
bit
sir,
more.
we will come back to you just to continue the case. Nagarjuna sir, when we actually saw this report and GPA, granulomatous polyangiitis, vagus, all were on card. So I was just texting you, sir, this girl 2 weeks back was absolutely fine. I tracked back the whole history of her 15 years childhood. Never she had any constitutional symptoms. She was actually a bouncing child, and her CUV was normal, her everything was normal. Now, can this all be a triggered by something like we know? Okay, we now talk about a drug-induced vasculitis, which can be more predominantly MPO-based thing. P-ANCA, C-ANCAs are not common. I was actually asking those questions to you, and we were all talking about it. So whenever you come across these kind of pictures, sir, when otherwise normal child or a person comes to you in a 2 weeks of history, no constitutional symptoms, no arthralgia, no skin lesions, no any other symptoms of weight loss, any other complaints in the last 15 years, and all in an acute episode with a baseline normal values, normal creatinine, normal CUV, and suddenly in 3 weeks time you develop all this. So I was asking you, can this a infection trigger? Can this a drug trigger?
Yeah, I think, see, most of the GPA, granulomatosis polyangiitis, we diagnose are just like this only. They usually come with a subacute history. So, which means 2 to 6 weeks of illness, and that is when we diagnose them. And they're usually asymptomatic before that. So, just because they were healthy before the illness doesn't mean that there is some trigger. So, this GPA can come out of the blue. So there is no reason as of now identified why it happens and at what point of time it will happen. And the drug-induced vasculitis usually has a different presentation. As far as the lungs are concerned. So because I'm talking from the lungs perspective, so by the cavitating, the only vasculitis which presents with cavities predominantly is GPA, granulomatosis polyangiitis. All the microscopic polyangiitis, the drug-induced vasculitis, all of them present with diffuse infiltrates or diffuse alveolar hemorrhage. So I think for me,
that differentiates from drug.
this picture is very typical of a primary granulomatosis polyangiitis. It is, I would say, the textbook picture. The only thing is the stenotrophomonas. That is a secondary acquired infection. But at one point I very accept is that infections do trigger relapses of vasculitis. So once you diagnose GPA, on follow-up, relapses do happen, and these relapses can be triggered by infections. That I will accept, but I cannot say that infection will incite a new vasculitis to happen.
Probably there is a possibility there is a subclinical vasculitis in this patient, which was not evident because in the previous CT, as you rightly pointed out, there was no cavitation as such. Maybe there was a minor possibilities there, but most of the other lung parenchyma was healthy and normal. So there was a subclinical, and it is known that any drug or any infection can trigger a full-blown vasculitis, which is a possibility in this case. Which is the first, which is the second, probably we were all debating on that. Please go ahead, Srikant.
So by day 10, what the reports we received was CNK was positive, and at the time our differential diagnosis was whether it is a vasculitis or an infection-induced vasculitis or an autoimmune vaginous granulomatosis. And there was an AKA, and we thought it might be due to cotrimoxazole also. It was a newly started the drug along with levofloxacin. So after the 5 days of therapy, we have stopped. So the initial procalcitonin which was sent on day 4 was initially it was 0.77 at an outside hospital, and it was 6.08 at our hospital. And by day 10, after receiving the antibiotic therapy, she was symptomatically better, cough and SOB, and there was a decrease in the decrease in the prolactin. But there was an increasing trend of creatinine, which reached by 1.83 by day 10. So after a multidisciplinary,
Srikant, just a minute. Sir, Venkat, sir, a small doubt, sir. In the last slide, you mentioned in the differential diagnosis that there is a word infection-related vasculitis, sir.
Infection triggering, not related.
Triggered vas. Okay, thank you, sir.
I think those were, go back to the previous slides. See, the discussion was the creatinine rise started from 0.7 to 0.8 to 1.8 after starting cotrimoxazole. So even we are contemplating whether the cotrimoxazole also can be a contributing factor for an injury.
Partially, I may not agree with you, sorry, sir, because if we see the standard prophylactic treatment modalities for vasculitis, once the patient goes into the remission, the guidelines even suggest to use cotrimoxazole as a prophylactic antibiotic to prevent vasculitis.
Then agreed.
So if it is a potent drug that can cause vasculitis, I think we would have not used it.
No, not exactly vasculitis. I think Dr. Vijay, when he actually checked that cotrimoxazole and the kidney trend, he also felt like, okay, let me discontinue cotrimoxazole. Sometimes it can trigger things, or it can also be contributing.
It can trigger
so
definitely an acute kidney injury.
Maybe. So we have checked for any analgesics. We have checked for nephrotoxic drugs. We have not found anything except cotrimoxazole. So we discontinued that also in view of the doubt.
Yes, sir. As you said, discontinuing it at that point of time when there is an ongoing AK is a good decision, sir. But the thing is, like whether that, as per literature, we know that penicillamines, penicillin group of drugs, penicillamine, hydroxyurea, and hydralazine, and cocaine adulterated lebimazole, they can precipitate vasculitis. But there is very less data. No, I think no data that cotrimoxazole directly can cause
vasculitis. No, we are not talking about cotrimoxazole causing vasculitis. We were
at
that point of time.
Yes, sir.
Before we got the diagnosis, we were contemplating.
Okay.
Okay.
Thank you, sir.
By day 10, we have planned for kidney biopsy. And under the cover of, since we came Sianka is positive, under the cover of an antibiotics, after a multidisciplinary team of discussion, we decided to pulse the patient with the methylprednisolone dose initially planned for 3 days. And on day 10, the kidney biopsy was done. After the 2 days of pulse dose of steroid therapy, patient was symptomatically better and seems that puffiness of faces, there was a slight resolving as said by her mother. So a repeat CUE was done, which was showing proteinuria from reduced to 1 plus and the decrease in the number of red blood cells. And along with that, if we the trend, there was a decrease in the bilirubin level, enzyme levels are returning. And we see a decrease in the creatine value to 1.37.
So we will ask Dr. Nagarjuna. Ma'am, welcome you on board. Sorry in making you wait.
No.
Yes, ma'am, your important histopathology slides give us the clue. So please go ahead, ma'am.
Thank you. Actually, when Dr. Srikant asked me for the slides, I was very much interested to join the webinar to see the evolution of the case and the final outcome. So then I expressed to describe the slides myself. Okay, so we got a renal biopsy with the short history on the request form saying that patient is 15-year-old child and with history of fever, lower respiratory tract infection. And by that time, the case was quite very much worked up. Like it's mentioned like C ANCA is positive and C3 levels are also low. So because she's a child and C3 levels are low, I was expecting, and clinically it is RPGN. I was expecting infection-related glomerulonephritis with crescents. But then the biopsy is like this. So we have received a core of renal biopsy. Can you change the slides, Dr. Srikant?
Yes, madam.
So as per the urine report says plenty of RBCs. So you can see here, the tissue looks very busy in the sense the tubules which are supposed to be closely opposed, they're far apart. And this distance is increased by the inflammation in the interstitium. And as mentioned in the urine report, there's plenty of RBCs. Here you see the tubules very much dilated and these are filled with RBCs. And throughout the length of the core, it shows a similar picture. There's diffuse tubular injury with widened interstitium showing neutrophils, showing inflammatory cells. And coming to the glomeruli, there are about 8 glomeruli, all were viable. And the glomerular tuft, if you see, the tuft is not showing any proliferation of cells. Usually in any immune complex mediated glomerulonephritis like infection-related GN, we see proliferation of cells in the glomeruli. But here the tuft was not showing any proliferation. There is extra capillary in the Bowman space proliferation of cells that is forming a crescent. Can you go to the next slide? Here, the next slide. I want a closer picture of the glomerulus which I have sent. Yeah. Okay. So this is the glomerulus. This is one other glomerulus. Here you can see the tuft and there's some kind of pink smudgy appearance here. There's no Bowman space. The Bowman space is completely filled up by the cells. So here is this in some not all the glomeruli show the entire picture. So in this particular glomerulus, here you can see the cells which are occupying the Bowman space. That is, these are the cells forming the crescents. So whenever there is vascular injury, and when the inflammatory cells seep out into the Bowman space, that triggers the formation of crescents. That is, whenever there's vasculitis, we see the crescents. The next slide. So here you see a typical picture of the crescent, a semilunar proliferation of the cells occupying the Bowman space. And here, there's smudgy appearance of in the capillary tuft. This in the special stain, we do Mason's trichrome to identify any blood products. Can you go to the next slide? Okay, so almost every glomerulus is showing cells occupying the Bowman space, which are forming the crescents. The next slide. Okay, this is the Mason's trichrome which I was talking about. So here, the Mason's trichrome highlights the blood components. They can be RBCs, or they can be cytoplasm of the cell, or they can be fibrin products. So the appearance, the smudgy appearance of the frixolophilic stain makes us understand that, okay, this is fibrinous exudate. So this is happening because the vessels are injured. So thus it is a necrotizing glomerulonephritis with crescents. It is a crescentic glomerulonephritis, and that is necrotizing injury of the underlying vessels. So every renal biopsy, apart from the light microscopy study with all the special stains, we do immunofluorescence. The next slide. Okay,
Ma'am, your camera is off.
oh, sorry. Yeah. Okay. Fine. So this is immunofluorescence. In the immunofluorescence, we use panel of antibodies, that is IgG, A, M, then complement C3C, C1Q, kappa, lambda. So this is how there were no immune complex deposits, significant deposits in the tuft. This is one tuft which is not showing any crescent. These are the other tufts. Here the space is occupied by the crescents again. No significant, you can see that there's no bright granular lightening or of the immunoglobulins that we have used. This is IgA, then this is IgG, C1Q, all were negative. Next. The next slide. You're going back, I think. Yeah. So this is just entrapment. Otherwise, this is the underlying tuft is not showing any significant positivity with any of these complements or antibodies. So the diagnosis, the impression upon the biopsy is it is pauci-immune because there were no significant immune deposits. Necrotizing, as I've shown, the fibrinous necrosis of the injury of the vessels. Crescentic glomerulonephritis. There is severe tubular injury. As I've shown, the tubules were very much dilated, interstitium is widened, and tubules filled with RBCs. Only occasional tubules with thyroidization, saying that not many tubules are showing features of atrophy, which is good for the patient. So this is the pathological impression, pauci-immune, and this is correlating with the ANCA results that you have got.
Okay, ma'am. Thank you, ma'am, for bringing this. I think the slides and the pictorial depiction adds a lot of value to this all slides, ma'am. Thank you for your inputs and also being available with us.
Yeah,
Mahesh,
I'm happy to know the evolution of this case and the final outcome.
Mahesh, any comments on this?
No, sir, no comments. This is straightforward. As we discussed previously, we would go ahead with by doing a renal biopsy, and it is typically showing less immune deposits than pauci-immune with a crescent. We will always take it for granted that this is a typical case of vasculitis. But if uh, if we see literature and our routine practice, if someone has ANCA vasculitis positive, either it is a C ANCA or P ANCA, we should always look for anti-GBM antibodies because there will be an correlation. I mean, there is an association double positivity, and at the same time, we should look for ANA also because there is a 5% chance that the patient might be having ANA positivity and at the same time ANCA positivity. And when it comes to the treatment, if it is a dual positive with ANA positivity, we should treat the patient in the induction phase like a vasculitis and maintenance phase like a lupus case. If there is a double positivity with anti-GBM antibodies and vasculitis, we should treat intensively like a anti-GBM antibody disease, and at the same time in the maintenance phase we have to treat it like a vasculitis. So based upon the type of other antibodies that are present in a patient, our treatment protocols definitely will be differing, sir. So at this point of time, if someone asks me, I would look for other antibodies in this patient. Anyway, ANA was done, which is only 1+. I would always go and check the anti-GBM antibodies in this particular patient because she has a crescentic glomerulonephritis and because she is in the particular age group where anti-GBM antibodies can be present. But the other point which is going against anti-GBM disease is no immune deposits. If it is a typical anti-GBM disease, we know that there will be a significant linear deposition of if in immunofluorescence, we will typically see the typical linear deposition, which is not there in this patient. So as a conclusion, we can take it for granted that this can be a typical vasculitis patient, and there is a less chances of the getting anti-GBM antibody positivity, and at the same time we can little bit neglect that 1+ ANA positivity which is present in this patient.
Dr. Maturu, this is regarding the therapy after the pulsing. Initially, we had a discussion whether it has to be a steroid pulsing and continuation or another modality of a dual, either a rituximab or a cyclophosphamide or a mycophenolate. all these discussions happened. So what is your take from here? How do you go about most of your witness cases with multi-system involvement?
So I think we should stop using the word Wegener's, though we are all used to it.
Yeah, GPA is the
has to
new
be
term.
GPA. So whenever we have an active GPA, so this is systemic granulomatosis polyangiitis, because there is involvement of more than one organ here, both kidney and the lungs. And the second thing is, it is life-threatening, organ-threatening disease. So it's an active, systemic, organ and life-threatening vasculitis. So that is where we put it. So the thing is, we have to be aggressive first. There is, as in our case also, the day we got the diagnosis, the next day everything was started. So we have to be aggressive, number one. Two, there is always two phases, the induction phase and the maintenance phase. I think Dr. Mahesh also will agree with that. So induction, the medicine which acts fastest is the steroids. So that is why we have to give pulse steroids the moment we diagnose GPA. In fact, today also in the OPD, we had one case where we had red eyes, lung cavities again. They were diagnosed 5 months back, but the treatment was half-hearted. So she came with a subglottic stenosis, life-threatening. So if you are not aggressive in your treatment, it is going to make you suffer. There may be some partial response, but it is going to relapse. So always induction is with two agents. One is steroids, second is a non-steroidal agent. Pulse steroid, whenever you have an organ-threatening disease, pulse steroid has to be given, which was given. Now the second agent, again, ideally it has to be either pulse cyclophosphamide or rituximab. So there is now a lot of data comparing both of them, and let us not go into all those intricacies. In this case, we had discussed, but the only problem was the presence of the Stenotrophomonas. And we had given only 1 week of antibiotics. So we decided that let us give pulse steroid, at least get the disease under control and be not very aggressive with the second agent. So we started induction with mycophenolate. So I would say that if we have a serious life-threatening disease, at any point of time, induction with cyclophosphamide rituximab will score over induction with mycophenolate. But here, because of the coexisting infection, we had decided to choose mycophenolate as our steroid sparing agent. And then once you have the remission, so there are criteria, you have to actually do the scores and all. The BVAS score is usually calculated, and once you have remission, then you start the treatment maintenance phase. So this is about how we do. In our practice, whenever lung is involved, it is usually organ-threatening vasculitis. So we usually give pulse steroids, plus we talk to the patient about cyclophosphamide versus rituximab, and then it is always a discussion between the patient and the doctor.
Shared consent and shared discussion.
Yes, so because each has its own risks and benefits. Cost will also picture. So rituximab is more costlier than cyclophosphamide. So several things have to be taken into consideration, and then we decide the line of action.
Again, probably a direct personal question. So this patient, initially we wanted a lung biopsy because we had no clue of renal being involved.
Correct.
Later on, we got a clue that renal is involved. We holded back the lung biopsy because the INR looks high, so we wanted to stabilize and get back. Now the kidney got involved, so we got a clue from there. This biopsy may give us information. So less invasive skin, kidney, and sometimes it both of not there, lung. So how do you take it?
So now the role of biopsy in diagnosing role of lung biopsy in diagnosing vasculitis. I will tell that it is not very, very much, because see, now in bronchoscopic biopsy, we only get very small pieces. We won't get large pieces. So in a case of GPA, even if we do a lung biopsy, we will get necrotizing granulomas or granulomas. Correct. So very unlikely that we will get a histopathologic characteristic of vasculitis on a small bronchoscopic biopsy we get. So in this case, actually the whole intent of biopsy was thought before we had the CUE and the C-ANCA. So the moment the C-ANCA report came strongly positive, we never, we don't want a lung biopsy. The role of bronchoscopy then only is to rule out infection. We are very, very clear. And for that, we don't have to do a biopsy. A simple BAL will suffice. That now whatever infections are there before we escalate immunosuppression. In GPA, kidney biopsy is actually more helpful because it gives us the classical active crescents and whatever it is. So when we have a pulmonary vasculitis, I think the diagnosis is more based on radiology, immunology, ruling out other causes. But if we can get a big biopsy, like a surgical lung biopsy, then you will see all those small vessels, the perivascular inflammation, vasculitis, and all those things. So I think that is how I put it. GPA on
How differentiate it from CT guided lung biopsy from the lesions with the cavity?
Now both will give the same size of tissue. I don't think even CT guided biopsy here would have confirmed the diagnosis of vasculitis without C-ANCA being positive. For if you ask me, suppose you don't have the ANCA positive and we do a biopsy, can we confirm vasculitis? The answer would be no, from the lung biopsy.
So,
Yes,
Srikant,
Sir,
yeah,
just
ma'am,
couple of-
ma'am wanted to some comment. Ma'am, you want to say something?
yeah, I wanted to
Switch
say
on your mic, ma'am, camera, ma'am.
yes. I wanted to say that it is easy to diagnose vasculitis in kidney biopsy than in lung biopsy.
Agree,
Once
ma'am.
we see granulomas, we tend to do special stains for infections. We do see vessel injury, but that is out of exclusion. But kidney biopsy, it's easy to diagnose vasculitis because it will manifest as crescents.
Agree.
Sir,
Srikant,
just
That
to
is what
add,
I said also. When we have vasculitis, I think it is the immunology, ANCA, the C-ANCA, P-ANCA, which actually clinches the diagnosis.
just to add a few points regarding the workup of this patient, sir. When it comes to vasculitis, why we always insist like just put a nephrology referral or nephrology consultation is like, if you see the classification of vasculitis, we know that it is divided into large vessel, small vessel, and medium vessel vasculitis. When it comes to large vessel vasculitis, kidney in the sense involvement of kidney typically give a clue that the patient will be having very high blood pressures, accelerated hypertension, vasculitis involving the main renal artery. They can give this kind of picture. When it comes to the medium vessel vasculitis, the kidney will give in such a clue that in MR abdomen, if we see MR angio, there will be nodular appearance and at the same time pseudo aneurysm formation. Similarly, if you do a biopsy, because the kidney is having all the three types of vessels in the sense large vessel, medium vessel, small vessel. If you want to typically pick up some systemic vascular insult, the kidney will be an ideal organ to do a biopsy and see the main picture what is going to happen. So offering a biopsy in this patient is a good thing that it is going to give a diagnosis, number one. Number two, as Venkat sir asked, is there anything that we can offer further to see? Now there is a trend to see the urinary biomarkers. Sir. They are giving in the sense if the patient is having vasculitis and if the patient doesn't have anti-GBM disease or lupus, there is some specific biomarkers like CXC13, TIMF1 and CD116 which are specific for vasculitis. So this kind of biomarkers will definitely give a clue that this patient is having a vasculitis. And coming to the type of antigens
Maybe
that
you're
what we are
talking
seeing.
about ANCA negative vasculitis can also
No,
be.
sir. ANCA positive vasculitis in the same background of double positive antibodies, or say if this patient has a 2+ ANA, we are not sure that whether the patient is having a double disease like lupus along with vasculitis. Suppose if the patient gets anti-GBM antibodies positive, and if you are unable to do a biopsy, we are only at the serological diagnosis. Just we got CANCA positive, and if the patient has anti-GBM antibody positive, but the patient is having severe coagulopathy where we cannot do a biopsy. Biomarkers will definitely give a hint at this level. And at the same time, now we are checking the epitopes of even MPO antibodies or anti-protease 3 antibodies. There is an upcoming data that their sub-epitopes of this, in the sense HLA DQ episodes point towards anti-MPO antibodies, and at the same time HLA DP. There are some new epitopes like I just remember one is DP and Serpina is one new epitope
So
that what we have.
we are also evolving into urinary biomarkers more
Yes,
and more. in the
urinary biomarkers and looking into sub-epitopes of the particular antibodies, anti-MPO antibodies or anti-protease 3 antibodies. So this will definitely, in future, it will come into the market, sir. We will
Srikant,
definitely go to that stage.
over to you.
Yes.
Govinda.
So we initially planned for 3 days of steroid therapy. We continued for 5 days and discharged with oral prednisolone and mycophenolic acid. And this was the initial chest X-ray at the time of admission, which was showing he's in time of discharge. There was some resolution in the pneumonia appearance. So final diagnosis was C-ANCA-associated vasculitis with rapid progressive glomerulonephritis with post-immune glomerulonephritis with background of some infection and other organ involvement. So these were the happy faces by the time they were leaving our hospital.
So long way to go at this point of time. At least we could discharge with them. So they will be under follow-up of the multidepartmental team. So again, this is an example of as a Department of Pulmonology, Department of Nephrology, and Department of Histopathology, mainly renal specialized hepatopathology, helped this patient along with the Department of Critical Care Medicine, which actually brought all these discussions together. So this is actually a case where it started somewhere with a community-acquired pneumonia, ended with an crescentic glomerulonephritis with C-ANCA vasculitis. So with this, I thank all the participants and the Dr. Nagarjuna Maturu sir for your time and valuable inputs and the discussion of this case. Sir, thank you for joining us and again enlightening on this case. Thank you for your time and valuable suggestions, sir.
Just final question now. So this is finally the infection triggered ANCA-associated vasculitis.
We were not sure, ma'am. Actually, as
Except for the age.
these were all discussions happened because initially the patient had no clues, but Dr. Nagarjuna Maturu said that most of the times the presentation will be de novo. They come with a subacute of 2 to 3 weeks and they present like this. So I was actually asking these questions. No constitutional symptoms, otherwise healthy, normal CUV, normal creatinine at presentation. After 3 weeks, all this started. Can this be a trigger in a subclinical vasculitis? That's a possibility. That's what actually Dr. Chakravarthi sir and also other team members felt. But yes, this is also a possibility. Thus, the patients de novo present with vagus as a pneumonia and had a secondary stenotrophomonas, which is a catch in the hospital stay also. That's what I think is the opinion. So at the final, we've all agreed that this is a C-ANCA vasculitis, that is a GPA with multi-system involvement with an RPGM, responded to a pulsing steroids and therapy, which is responded to.
Thank you,
Those were all discussions whether drug or infections also could have been triggered this. Those are all the differentials which are considered during our discussions with all of them. So we try to bring all of that into the case so that it will look like a natural thing, and how CUV was actually initially was normal, so we kept delayed, how 0.6 was considered normal to 0.7 to 0.8, then it suddenly jumped up. We thought of a pneumonia, sepsis, AKI, drug-induced AKI as initial phenomenon, and Dr. Mahesh commented that a early nephrologist opinion in the beginning could have been changed the game at that point. So these are all live stream. That's where we were discussing. And we initially thought to go for a EBUS biopsy with Dr. Nagarjuna Maturu because INR was high, we hold it back. It is a live case, ma'am. And we try to bring the case as it is because all of them, the clinicians who are a seasoned clinicians, very reputed, they are all here. So we try to bring the case as it is to have a discussion, to have a learning experience from this case.
I think two comments. One, had we done EBUS also, we would not have got a diagnosis in this case. So INR actually helped us defer the procedure for the best of the patient. One. Two, vasculitis, how many ever vasculitis we diagnose, they are all missed. They're all missed. So I think it is always important to have a very, very strong index of suspicion. The only thing is that we do not think, we do not suspect, so we do not ask for ANCA. That is where the problem comes. So I think anyone who sees this webinar should go home with the take-home message that whenever we have multi-systemic involvement, always think of vasculitis. Whenever we have a non-resolving pneumonia, whenever we have a cavitating lung disease, please think of vasculitis. Fever does not mean infection, point number 1. 2, cavity does not mean TB, point number 2. These are the things which we have to remember.
Thank you. Thank you, Dr. Mahesh and Dr. Chakravarthi sir and Dr. Vijay. All three of them are our nephrology team who actually has helped us in bringing this case and cracked that. And thank you, Dr. Sagarika ma'am, in bringing those histopathology slides. It was a pleasure to have you
It
here.
was my pleasure to be part of this webinar. Knowing the case, we don't get to know the proper history or outcome always. So.
And thank you, Dr. Srikant. In a short time, you agreed. Dr. Srikant joined as a new consultant in the Department of Critical Care Medicine in Hitec City. He was a DrNB postgraduate from our same institution in Malakpet. Thank you and bringing this case, and so elaborately you brought Srikant, even though you had a partial information, but you tried to bring every possible information. Thank you, Srikant.
And at the end, I should thank Dr. Venkat for excellent moderation and for choosing this case.
Because of all of you, I could actually carry on, sir. Thank you.
Yeah, sure. Bye-bye.